Hello everyone. Today we are going to discuss an article and its aim is effectiveness of neural mobilization with intermittent cervical traction in management of cervical radiculopathy, and it's a randomized control trial. So now before we begin discussing about the article, let's first understand what is cervical radiculopathy, what is neural mobilization, and what is intermittent cervical traction. So now cervical radiculopathy is basically a peripheral nervous system disorder affecting the normal function of cervical nerve roots, and it is often associated with chronic pain and functional limitation in daily life. Cervical radiculopathy is associated with mechanical and or inflammatory stimuli around the cervical nerve roots, and several imaging studies have demonstrated cervical disc herniation and osteophytic enroachment to be the most common lesion that leads to nerve root compression, inflammation, or both. A variety of manual therapy techniques, including intermittent cervical traction and neural mobilization, have been proposed to reduce the pain and functional limitation in cervical radiculopathy. Intermittent cervical traction can modify mechanical stimuli, compressing the involved cervical nerve roots by increasing the intravertebral space. It has also been suggested that application of intermittent cervical traction can disperse inflammation at cervical nerve roots, and neural mobilization was actually introduced as an intervention for pain relief for more than 25 years ago and is advocated in this present study. Cervical traction has been applied using the grades 2 to 4. So grade 2 is basically described as large amplitude longitudinal movement within the available range of motion. Grade 3 is large amplitude longitudinal movement that reaches the end of range of motion. And grade 4 is the small amplitude longitudinal movement at very end range of motion. So now let's discuss methods. So in this present study, a randomized controlled, this is a randomized controlled design study, and in this study, it has been investigated changes in pain function and disability of participants with cervical radiculopathy receiving intermittent cervical traction with neural mobilization. Participants were randomly allocated using block randomization to an intervention group receiving neural mobilization with ICT, that is intermittent cervical traction, and the other group was control group. In both the groups, 21 participants were allocated. And in control group, they did not receive any type of treatment, and participants in both the groups were asked to avoid prescription or over-the-counter analgesia or any inflammatory medication, and were assessed on outcome measure based applied at baseline week 0 and at the end of 4-week program, that is at the week 4. Participants randomized to the intervention group received the final assessment 1 day after their last treatment session. Inclusion criteria were as follows. Participants diagnosed by orthopedic surgeon using MRI or CT scan as having unilateral cervical radiculopathy were referred to outpatient physiotherapy department, were initially recruited. Participants reported unilateral sensory and motor deficits, including sharp pain, muscle weakness, and numbness in the upper arm. And if there was a positive result, was found in minimum 3 out of 4 tests. Those were Sperling, distraction, upper limb neurodynamic test, and ipsilateral cervical rotation of less than 60 degree. Now, exclusion criteria were as follows. Participants were not eligible if they had a current history of cervical myelopathy or signs of upper motor neuron disease, bilateral cervical radiculopathy, or other musculoskeletal conditions in the affected limb. Participants were excluded if they had been receiving any prescription or over-the-counter analgesia or any inflammatory medication during prior 2 weeks of the research study. Now let's talk about intervention. Participants were scheduled to attend 12 treatment sessions, 3 sessions every week for 4 weeks for 15 minutes each session. At the beginning of each session, participants rested in a supine position and were advised a position that their cervical spine is in the most pain-free position. Once the starting neck position was achieved, neural mobilization combined with ICT were performed by 2 treatment providers. Each session comprised of 6 sets of grade from grade 2 to grade 4. In each set, intermittent cervical traction was applied and maintained for 1 minute and was followed by the rest period of 1 minute. Maintaining the intermittent cervical traction for a minute, slider neural mobilization using a median nerve bias were performed in slow and oscillatory fashion at the same time. Now, statistical analysis. A two-way repeated measure ANOVA was performed to identify the potential statistical significant differences between the intervention group and the control group with alpha set as 0.05. The intervention group demonstrated a significant improvement, and post hoc pairwise comparison demonstrated statistically significant difference between the measures for NDI, PSFS, and NPRS in the intervention group from baseline to week 4 follow-up. That is, P was less than 0.05. Now, NDI, PSFS, and NPRS are the three scales that were taken in each of the participants. This suggests that the neural mobilization, which was applied simultaneously with cervical traction, can provide pain reduction and improvement in function and disability. Moving ahead, in discussion, we have seen that these findings suggest that over a period of 4 weeks, the combination of these two manual techniques can reduce pain and disability and increase the functional strength, grip strength, and active range of cervical motion. In contrast, participants in the control group demonstrated a deterioration of symptoms between the measures, although most of these changes were not significant. A slider neural mobilization of a median nerve was applied to mobilize C6 to T1 nerve roots, which is the most commonly involved nerve roots in cervical radiculopathy. Sliding techniques were applied because they had been more comfortable than tensioning techniques in the patient whose irritability and severity of the symptoms were high. This was the first randomized controlled clinical trial exploring the effects of simultaneously application of these two techniques, that is neural mobilization and intermittent cervical traction. So now let's talk about strength of the article. So first of all, a block randomization was used in order to minimize the potential selection and accidental bias, as well as to achieve a balance in the sample size between the groups. The treatment providers were qualified physiotherapists with 5-year post-qualification clinical experience in the field of neuromusculoskeletal PT. The numeric pain rating scale, that is NPRS, was used to estimate the intensity of current, best, and worst pain intensity over the period of 24 hours. The neck disability index, that is NDI, and the patient-specific functional scale, that is PSFS, was used to determine the disability associated with cervical radiculopathy. The selected outcome measure have been used in a similar studies and have acceptable validity and reliability. Now, talking about limitations, the improvement in the outcome measure demonstrated by the participants in the intervention studies are limited to 4-week follow-up period used in the study. Participants included in these studies were not screened based on specific etiology and duration of symptoms. Also, neural mobilization may not be effective in cases where nerve root is under compression due to disc herniation or foramen stenosis. And neural mobilization of median nerve is given in this particular study, but the researchers never checked if any other nerve root was affected. Basically, neural mobilization technique used, that is median nerve bias, tends to bias the C6 to T1 nerve roots. Therefore, the techniques used in this study may not be effective in participants with cervical radiculopathy at any other cervical levels. For future studies, it would be of great interest if it could compare participants with cervical radiculopathy caused by mechanical versus inflammatory stimuli. This also brings an end to our discussion. I hope you guys enjoyed it. Thank you.